All right, good morning, everybody. Welcome to Advanced Pediatric Dentistry. By advanced, I mean we're going to water it down quite a bit. But this is just a lecture class. We have a lab to it. I am going to try to make it as straightforward as I can. We do have some other instructors that are going to come in and do some lectures. So Dr. Spivey, I don't think you guys had the pleasure of having her ever teach you, but she taught me. She worked with me now. She's amazing. She's a very good educator. Dr. Shooty, who you guys hate, I'm sure, she's awful. Dr. Costin, she will talk your ear off. That's okay. She's great. And Dr. Rawson. So I don't have Dr. Rawson teaching any lectures as of now. He might pop in, kind of thing, but and he might sub for me one of the days. I don't know. But we will go over just kind of nitty gritty, all of the kind of try to touch base on most aspects of pediatric dentistry here. I'm really, other than the slides, I'm not going to have like any questions from textbooks. So if it's not really on the slide, or if I don't talk about it in lecture, it won't be on the test or the final. So we are going to just have one final. Last semester I did do quizzes, but already scheduled, so it's Wednesday, April 30th at 8 a.m. I think that's the week before finals. And then you guys will have 25% is class attendance, participation, and attitude. For those quizzes last year, I did have a couple students that gave me a little attitude, so they got an 89.7 and didn't get an 8 in the class. So happy attitude. Yeah, final grades are not rounded. But the final is 75% of the final grade. And through the lectures, I'll kind of like jot out questions and stuff to kind of help you with the questions I will be asking you. I'm not trying to trick you. I'll try to make my questions a little easier. I guess my final questions last semester tripped up a couple, so I promise to make it easy. And I write all the other questions from the other instructors too, so it'll always be me writing the questions. So okay, so no quizzes, and then a couple. So yeah, Dr. Fry's gonna come in. She's gonna teach occlusion, but we do have one in between. Hopefully that's not too confusing, but that's just how it was best for her to come in. And then Carson, the same thing. She has a week in between, but hopefully everything will go fine. Oh, I do have a makeup day if we do need it, or we could try to put the final that week if it comes to it. Sometimes the lecture or the testing center is already taken, so we'll see. But right now, final on the 30th, no class finals week. We do have a makeup day. So okay, any questions about syllabus and course stuff? All right. Now, if I do start seeing that some of these seats are empty, I will start taking attendance. So. All right. And I don't know why this isn't going full screen. So, great. Pediatric exam. So this is kind of the basic kind of things you'll do at that first exam when they come in. I'm not sure how they do it here in clinic now. We used to have them come in for like a screening appointment to see if they qualified to be a patient. Not sure if they still do that, but if they don't, this is still going to be your first exam when you see them in the pediatric area. So med history, all this. So med history, commonly kids don't have very extravagant medical history. They're usually pretty healthy, but these three are the most common types of childhood diagnosis that we do see quite often in our practices. So asthma, ADHD, and autism. So just remember the three A's kind of thing. This will be on a question. But I'll pick out asthma here. What is a very important thing to ask the parents if their child has asthma? There's two very important questions. Yes. Do they take an inhaler? Is it managed? Do they have that inhaler with them? They really need it with them. And then the other question that you need to ask is what triggers it. So if it's like a stressful situation that triggers it, the dental office can be a little stressful for kids. So just make sure they do have that rescue inhaler with them. Yes, in our crash carts and stuff, we will have one, but just liability stuff, there's usually just one. So, of course, if you use it that one day in the morning for a kid, karma's probably going to get you. You're probably going to have to use it again in the afternoon. So, this is more about parents, the parents keeping up with their kids too. So, all right. We also do a good medical history with review of systems. So does this child have any major diagnosis? Are they seen by a cardiologist? Are they seen by a neurologist? Have they had seizures? Stuff like that. Like I said, usually it's very rare for this to happen. We wouldn't see these patients here at the school. More likely if they have any cardiac or neurological issues, they'll be seen at a hospital. But we do need to get a good review of medical history. When you get out in the real world, it's really nice because your assistants do that, but here at the school, you guys do all of this. So just make sure you're still getting a good thorough medical history. some fluoride varnishes did have tree nut residue or something, so that was a huge thing a few years back where kids who had nut allergies could have fluoride. Now they have new fluoride. So, have they had any previous surgeries where they went under general anesthesia? Did they do well? Did they wake up okay? Stuff like that. And then we do want to get their weight for the child. And why do we weigh our patients? There's two really big reasons why we'll weigh our patients. I'll let you think on that because the answer is in a few percent. Okay. Another important one is dental history. As a pediatric dentist, why are they here? Is this their first time here, or have they been to a general office where that office tried some treatment and went terribly wrong, and now they can't be treated in the chair? So, have they been seen by dentists? Yes. How was their experience? Were they cooperative? Extremely tempted? Any previous trauma or habits? So, of course, our little toddlers they can fall and hit their mouth. So, I would say it's fairly common to have E or F, the front two. One of them to be a little bit discolored just because the kid has fallen and hit it. So, and then do the parents help brush at home? Does anyone know the age that we recommend parents to brush their teeth up till? Or 6, 8 or 9. A good indication, which now I feel like kids don't even do this, but is if they can tie their own shoes. So if they can tie their own shoes, they may have the mental dexterity to brush really well. But yeah, up until 8 or 9, we do recommend parents at least do a run through afterwards, just because those kids, I mean, they're not going to do a great job kind of thing. So we do get a lot of parents like, oh yeah, like they're 3 or 4, like, yeah, he brushes himself, and we're just like, is he really though? Kind of thing. So just, of course, always be kind. Just be like, well, we just recommend it just because their dexterity isn't up to par. Okay, social history. Who does the child live with? Are they a foster kid? Do they have siblings and all of that? A big thing that I do like to tell my parents, especially if the kid has treatment that they've never had treatment before, is I ask, is there any brothers or sisters in the house if they're not at the appointment? If they're older, I tell the parents, don't let those older kids talk to those kids about treatment, because that's whenever they get scared. And of course, the older siblings are going to try to scare them. So, you're going to get a shot, they're going to pull your tooth, and then your appointment is already cracked. So, just know the social history, mom and dad's dental history. Just going to be honest, here at the school, whenever you have a kid's patient here, you will more than likely look at the parent and they are missing front teeth. So, the parents are neglectful of their oral hygiene, more than likely the kids aren't getting their necessary oral hygiene either. What grade are they in? Is it age appropriate? Are they up to par into that age group that they should be? Are they doing okay in school? Are they tired? And then do they have a developmental delay or learning disability? What's a big topic now in the dental world where kids might be underperforming at school and being really tired? Airway issues, yes. Sleep apnea. So that's a kind of a big topic that we're trying to kind of coordinate with ortho and Peds and all that, and ENT. Just because like if kids are really groggy and sleepy in school, they might have sleep apnea and airway issues. Here. Okay, school forms and consent. So it's actually very beneficial for kids to live in Illinois because Illinois does require each child to have a dental exam before kindergarten, 2nd, 6th, and 9th grades. So at least these 4 times these kids are seeing a dentist. A lot of times that will be like a mobile dental team going to a school and doing exams. That does count. So they will get a form, and I think you guys will do that in the first year. So those schools, I do think those count. there? No. Do you take x-rays? No. But at least the parents, they can have like a sheet that says that their child does need to see a dentist. Informed consent. So informed consent is going to be the process in which a healthcare provider educates a patient about the risks, benefits, and alternatives of a given procedure or intervention. So if a kid has a cavity, what are our options? It's just a interproximal cavity, doesn't need nerve treatment. What are our options for this cavity? Billy. That's a C. So those are going to be the main two options. Depending if that's the only tooth in the mouth, you can tell the kid's not cooperative, we can't do an x-ray. Another option for that kid will be silver diamine fluoride. So yeah, whenever you diagnose C cavities with kids, you do have to explain to the parents all the options that are there. So obviously a lot of parents aren't going to want stainless steel crowns. Actually, I haven't really had that big issue with that. But you do have some, like they're like, oh, can we please not do the silver, let's do the white. And then you just have to use your professional judgment. Is the cavity too big for white? Stand your ground, or all that. But definitely informed consent. You have to, and this is for adult dentistry too. You have to let the patient know what the plan is and all of that. Okay. Who can and cannot consent for pediatric patients in Illinois? It has to be a legal guardian, or their legal guardian has to have their name on their forms in the front. So at school, the front is very good at knowing who can and cannot consent, but in office, usually it does well too. But yeah, we do have some aunts and uncles, maybe bigger siblings, older siblings coming, and if the patient does need treatment, those people cannot consent. The parent either has to come in and sign, or now we can kind of do like messages, email stuff, but parent or legal guardian needs to consent. Special consideration for consent, special needs adults, sometimes they do need a guardian to consent on things, and then a teen mom. So she has a baby at 16, she technically is now qualified, considered an adult, so she can actually consent for her child. I remember our class, we had a question like, can she even consent for herself? Yes, at that time she just changed from teen to technically adult if she has a child. Okay. Chief complaint. Why do we ask chief complaint? We want to know why they're here. Is it always going to be the same for each patient? No. There's many different chief complaints, but a lot of them that we do see is we were seeing at a different office and they have a mouthful of cavities, so they refer me to you guys. But it can be for pain. That's a lot that we get here at the school. Spacing issues. That's not as bad for smaller kids. We'll get some parents that ask like, well, their teeth are kind of crooked, like the baby teeth, like any braces, and we just kindly tell them, no, we'll wait till the baby teeth fall out and they get 8 or 9 and they have some adult teeth, we'll get you erupting teeth. There are some different things that can happen with erupting teeth, especially on the molars. You can have eruption cysts, which look worse than they are because it has like that blue, it's like a blue cyst, so it looks like a bruise. We can just monitor those, and then of course teething. So they'll be sore, sensitive, and all of that. Really not a good remedy for teething, other than tell the parents get some cold ice cream kind of things, let them chew on it. But I do try to tell the parents to avoid Tylenol and ibuprofen until it's like literally unbearable, just because you don't want to just rely on those pain medications in an actual kind of thing. Mobile or over-retained teeth. So do we need to help take these teeth out, or can they get them out at home? That will happen a lot with 24, 25 coming in legally to O&P. A lot of times just gravity and just natural, like your tongue pushing it forward. They usually will become loose, but there has been a couple times where I have to help out O&P. The 24, 25 is like all the way erupted, like completely completely up and OMP is not mobile, more than likely you're going to have to help them out. If OMP is just like kind of partially and 24-25 is partially erupted and OMP are a little bit mobile, just give them more time. Especially because at what age would OMP be becoming mobile? Around 6. Yep. So are you really wanting to treat a 6-year-old and extractions and doing all that? No. So you're just gonna know that and say, we'll give this more time off. If we if we see it, if we see him in 6 months and it's still there, then we'll kind of consider taking it off. Another is bad breath. So postnasal drip, GERD, dirty tongue, caries, and then tonsils. I feel like most times whenever the parent comes in, and, they say it has really bad breath, they're cavity free, their tongue's clean, and all that. It's usually the tonsils. And I ask, oh, do they get sick often? And I go, oh my gosh, yes. So bad breath, they could be tonsils. So sometimes you give an ENT, ears, nose, doctor, referral for that. Staining, so yeah, if they took iron supplements or anything, they can have black stains on their teeth, and then grinding. What can we do for grinding in the primary dentition? Yeah, nothing really. We just say it's very common, and then when the adult teeth come in, they usually stabilize out. So, sorry, parents, there's really nothing we can do. I personally don't have kids yet, but I haven't heard actual grinding, like kids grinding, but apparently it's really, really bad. But again, it's not uncommon, so you just tell the parents, yeah, like that is common for kids. We'll reassess when the 6-year molars come in. Sometimes it can be so bad where the teeth do wear down to where you're seeing kind of the pulp, like shadows of the pulp chamber. In those instances, I just kind of show the parents in the mirror like what I'm seeing, and I'll say there's a chance that we might have to do something, but the teeth naturally react to that. So we have like dentin laying down just from all that force and stuff. So a lot of times we don't have issues with those teeth, even though you see so much wear. Okay. Another thing we need to do is just the general appraisal. So that's when the patient just walks into the room and you're just looking at the patient. So you want to just observe just their body, how they walk, their body language. Are they kind of clinging on to mom and dad? Are they walking in confidence? Are they happy to be here? Are they scared? So this is just general appraisal. And in our minds, like as the dentist, like how's this going to? What am I going to do? Height, weight, and vital signs. So blood pressure, heart rate, temperature, presence of growth signs and symptoms of disease, vital signs. Could be a little swayed if they're upset or anxious, and then BMI. So why do we weigh our patient? That is for drug doses calculation and local anesthetic amount. For us here in Illinois, we don't do as much moderate sedation, so that's when they take medication, they drink it, and that's what you would do dosage for that. We don't do that a lot here, but we do local anesthetic amount. So yes, we'll calculate. We have that lecture later on in the semester, but a kind of good fast way is for every 25 pounds the kid is, you can have 1 arm. It's not exact, but if you're ever in doubt, that's Can you overdose on, or is there a reversal for local anesthetic? No. So do not overdose on it. And for kids, they really don't need that much. For a lot of it, we'll just infiltrate. So if I'm doing a class 2, I usually just infiltrate on the buccal vestibules, half part for even like 7-8 minutes, and maybe. So don't overdo it with anesthetic. Okay, again, this is kind of general appraisal. Should we treat this patient today? If they had a fever or vomiting in the past 24 hours, cancel or reschedule. If they have pink eye, ringworm, impetigo, and lice inactive for 1, they are not going to be seen at our office that day. Okay, extraoral do for head and neck, I just kind of look them straight on kind of thing, see if there's any dysymmetry with the face kind of thing, if they have any spots on the face, and then assess their TMJ, so just your fingers right where they are, like right by the ears, have them open and close. There's not as much TMD in kids, but we do have some like in the teenage years that come in and they already do have jumping. They have a dislocation and then also palpate the submandibular. So intraoral exam. Lips, I mean externally, look at the lips, are they dry, cracked, have they been swollen? Labial mucosa, more than likely they are going to have fortis granules. That is just little like pinpoint, very teeny pinpoint bumps kind of on the inside of your lip. Pretty much everyone has them. They're fine. I have had one parent that's asked about it. I'm like, yeah, it's okay. Mucocil, so yeah, the fluid filled little ball kind of thing on your lip. And then the frenums, so and tongue ties. So the frenums, I would say the maxillary frenum. There's a lot of very tight attachments that you'll see. I'm kind of surprised by that. They do a lot of frenectomies with laser and stuff. I do have quite a few parents ask if they need to get a frenectomy with that, and the kid's already 1.5 or 2. So at least for me, in my opinion, I want to be more conservative with this. So if they're already functioning, if they're eating and sleeping okay as of now, I wouldn't do anything. But now, like if they were like like a week or 2 old and they couldn't feed kind of thing, like yes, I would go ahead and do the gingiva, color's normal. Color normal is lightly pink, but variations of normal will be dependent on racial pigmentation. So location, hearing about the CEJ, habits, okay, contoured. Really, we're not worried about the gingiva as much with kids as we are with adults in perio. I haven't had to probe anyone's go balance. All right. And tongue, of course, we have our papilla. Geographic tongue is one of the more common ones. There's no really thing we do to it. It's fairly normal. Sometimes they can have a little burning sensation with that. It's usually pretty sporadic, so ibuprofen, Tylenol. They could do some magic mouthwash or something, some liquid lidocaine to help with that if it's unbearable. Yeah, another lingual frenum, so might do a tongue tie. Mucosa, you have your linea alba, fortis granules, could be cheek biting, and then another actually pretty fairly common is a lot of abscess ulcers for kids. Again, not really much to do except time. They can do warm saltwater rinses kind of thing, and avoid acidic foods. But other than that, it's just kind of a waiting game. They usually go away in a week or 2. Trauma from ortho appliances. So yeah, most of you probably had braces. So yeah, the metal brackets. So as sometimes you wake up and they'd be like stuck to your lip kind of thing. Yeah. Card saw palette. Literally just like listening. All right. So palatine tonsils, Brodsky, and Malin-Pie. So Brodsky is going to be the degree of tonsil blockage. What are we evaluating Brodsky? What would this be for? Yes, exactly. So yeah, this is more going to be for, yes, if you are doing moderate sedation or general anesthesia, you're the airway access kind of thing. So if they have a Brodsky 1 that occupies 25% or less of the oral pharynx, so very open airway. 2 is still pretty open, 50%. 3 is fine. When we have a 4, that can be hard for, yes, intubation. And if you're not For general anesthesia, it's okay. I mean, there's really not much other option. But for oral sedation, they need to have a very clear opinion. This is just another little, I thought this was a little better graphic. Okay. The other one's going to be Malampati. So Brodsky's with the tonsils, Malampati's with the tongue, the base of the tongue, and compared to the soft and hard palates. So we have a class 1, it's still very open. Class 2, the base of the uvula is blocked. 3, pretty much the entire uvula is blocked. And then 4, uvula and soft palate is blocked. So those are just, again, same kind of thing with Brodsky. If they're too big, there's intubation and airway issues would be a higher prevalence than for class 1. I will have a question on Brodsky. All right. Hard tissue, so teeth, color, intrinsic stain from tetracycline or fluorosis, extrinsic iron. Surface, it can be hypocalcified or hypoplasia. To examine caries, you do need clean teeth, and then you need to be dry to see it well. Okay, wear pattern, so attrition, erosion, abrasion. I actually do see, for the grinding, you'll see attrition kind of thing, and then erosion. You do want to always ask if they had acid reflux, because they do. They make like little craters in the teeth. Not sticky, like, or anything to explore or touch, but so a lot of times you just watch them, and again, like I was saying before with the wear, you just show the parents, hey, this could progress to something, but usually it's okay. And then number, are we missing any teeth? Do we have any extra? For this, anyone know the most commonly missing teeth in the mouth? So yes, the first most missing is going to be the wisdom teeth, but a good little thing to remember it by is going to be the most posterior tooth of that subtype of tooth. So like the incisors, it's more common for the lateral incisors to be missing. For the premolars, it's more common for the second premolar to be missing. For the molars, the third molar to be missing. So easy way to think about it. For the dental exam, dental arches are U or V shaped. We will do a whole, we have occlusion lecture, so I'm just going to kind of not really ask much about this as of now. I'm going to skip that for now, but these are the molar relationships for primary dentition. It's not class 1, class 2, class 3. It's straight flush terminal plane, mesial step, or distal step. Okay? So flush terminal, that is from the very posterior aspect of the second primary molar. So flush terminal, and we have mesial step. So once you go down and mesial, down, and then distal step down, distal. But Dr. Spivey has 2 different weeks of occlusion, so I'll let her kind of based on all of that. And then I just do add this in. It's not very common, but just cancer prevention and detection, even for kids, teens and stuff. Just check it out. Okay, that's the first one. Let's go to toddler. Okay. All right. So, when should you take your kid to the dentist? Establish dental home by 12 months, or another way to put it is shortly after their first tooth erupts, or by 12 months. So, when does their first tooth usually on the normal range? When does the first tooth come in? are they? Usually OMD. So yeah, shortly after those two teeth come in, or by 1 year, 12 months. Okay, we still do perform a comprehensive oral exam. Is it going to be as detailed and everything as our other ones? No, it's going to be pretty quick. This appointment is more going to be education and anticipatory guidance for the parents than really like doing like a lot of like a regular recall for like an 8 or 9 kind of thing. Okay. So cavities are contagious. Are kids born with the bacteria that causes cavities? No, they are not. So it is transferred either by vertical or horizontal transmission. I will have a question on this slide. The vertical transmission is going to be from mother or caregiver to the child. Horizontal is going to be from members of a group. So family members of a similar age or students in a classroom. Okay. The major reservoir from which infants acquire this bacteria is from mothers. 70% of caries lesions are found in 20% of our nation's children. I would say that's pretty accurate. I would say I see 20 recalls in the day. I would say maybe like 4 of those patients like need general anesthesia or have like a lot of cavities. There might be some in between that like have like 1 or like the starts of some, but I would say that's pretty accurate. Most of our cavities are in the same group. And then it does affect the entire general population, but it's 32 times more likely to occur in infants who are of low SES, so low socioeconomic status, whose mothers or parents have low education level, and who primarily consume sugary foods. Now, does that mean that high SES doesn't get cavities? No. Sometimes those are the worst of them, and this isn't like a fact or anything, but I have a thought that just these wealthy and well-off families just kind of know they can pay for make it fixed, so they kind of neglect doing it. So, and that's not bad. But yeah. Okay. Exam breakdown. You will still get patient history. Have they had any health conditions, breathing problems, heart issues? Are they taking any medications? Or are they having any allergies? Again, it'll be rare at this age, but they could have had some type of, they could have been prematurely born, so they could have been 4 weeks premature, could have had like some type of heart complication in the beginning that's resolved, and you don't need to do anything, we used to let you know, stuff like that. So still get a good medical history. Data gathering, so you're establishing their caries risk and anticipatory guidance. Do they have any teeth yet? Discuss the next ones to come in. So that's a big thing that you will educate the parents on these exams is when to expect the teeth to come in. So first teeth come in around 6 months, and then it's usually around 3 months following for every 3 months. So we'll kind of get a couple more new teeth. Are they using a bottle? Are they taking it to bed? How often are they using it? Because if they are taking a bottle to bed and it's not water, then we will discuss about risk of baby bottle syndrome, which is baby bottle caries, and all of that. Are they crawling or walking yet? So you're going to want to discuss the risk of trauma, just because they are obviously they're learning to walk, so they're a little clumsy, so they can fall and hit their tooth. At least for my office, we have a doctor on call each week, 24 hours. So I just tell my parents, like if they do fall, don't go straight to the emergency room kind of thing. That's going to be a very hefty bill. Just give us a call, send us a picture, and we can kind of talk you through whether or not it can wait or we need to go in and see them at that time. Usually it can wait. I rarely have to go in after hours, but I mean, you do have to be more prepared. And I will say that's one of the, I wouldn't say cons of pediatric dentistry, but just because kids are much more active and risky, I would say, in how they play and everything, and sports and stuff, you do have much more after-hour calls than like a general or an adult dentist. So we do have to be available to help out our patients when needed. Okay. Pacifier use, sharing utensils. Again, vertical transmission. So yeah, say passy falls on the floor, parent picks it up, lifts it off, puts it back in the kid. The parent has cavities. Now the kid's gonna have the bacteria that cause cavities. Because yeah, cavities are contagious. Anticipatory guidance. Dr. Schutte also has a lecture on this one, so I'll just kind of run through a little bit. So yeah, there's general guidance for the mother. It's going to be just oral hygiene. That's to reduce the bacterial levels, diet, carcinogenicity of certain foods, and the role of frequency can increase chances of caries forming. Fluoride, that's to help remineralize an animal. Fluoride is a big topic now, and I have seen more parents in the past couple of years be a little more hesitant with applying fluoride. So, what is like the MOA, the mechanism of action of fluoride? You guys know?
I think it's incorporated into the tooth structure.
Yes. Do you know? Have you guys heard of the critical pH yet? What's the critical pH? So yes, 5.5. So that's when a caries can start forming. What does fluoride, when it exchanges out the hydroxyl group, what does fluoride change the pH, critical pH to? Change it to 4.5. So yeah, so fluoride exchanges that hydroxyl group and then changes the critical pH of at least that time that the fluoride is applied to 4.5, and that can kind of change out. So I've been starting to get a little more scientific with my parents. They're like, okay, yeah, we can do it. So yeah, use your education kind of thing. Try to be confident in what you've learned and all that. And sometimes you can sway some holistic people. Caries removal. So yeah, you will let them know. You'll show them the cavities in question. You let them know what you're going to do. But I'm running out of time, so okay, Dr. Schuette's going to have an answer for anticipatory guidance. I'm sure. Okay, proper position for exam, knee to knee. Give a big hug. I do have a video I'm going to show, so I'll show that video. Okay. So yeah, these white lines here, that's going to be early decay. A lot of times you'll see this with that high frenum attachment because they're not pulling up the lip and getting on the gum line. So that's another thing you want to tell your parents that have that high frenum or that strong frenum attachment. You need to lift up the lip, make sure you're getting on that gum line. Okay. I'll try not to ask a question on this slide. And after all exams, this isn't just the infant, you always ask if there's any questions that they have so far. It is a lot of information that you kind of spew, especially if their first appointment, they have no idea. I always was like, if you do have any questions when you go home, don't hesitate to call us after, kind of thing. But you do have to use like lay language and euphemisms, and so they can understand what you're actually saying.
In this video, we want to demonstrate a typical dental visit for a young child or infant. We don't expect a young child to sit in the dental chair like an older child or adult would. The treatment is completed in the knee-to-knee position, which allows the parent to have a great view of the child's teeth during the exam and also allows the parent to observe my brushing technique. The knee-to-knee position allows the child to stay in her parent's lap and hold mom's hands, which assists the dentist and also provides comfort for the child. This visit is a great opportunity to discuss brushing and home care, diet, and any habits such as pacifier or thumb sucking. The actual treatment is short and sweet for the child. We do a visual exam, toothbrush cleaning, and a fluoride varnish.
So very
and we just lift the lid and we look at those teeth. Oh, they're beautiful. Let's see which ones are in there, and I just kind of help open. You are doing such a good job. Oh,
Most times the kid's screaming during this, so you just kind of egg them on, tell them to scream louder.
Size of your teeth are a little juicier when you're laying down. Oh, Lisa. That is awesome. Awesome stuff. Already in on the bottom. Good job. Let's check the top. Check this corner over here. Perfect. And then we are ready for the
That's kind of the gist
toothbrush.
of the knee.
For a little
It's just
brush.
we try to make it a little bit more comfortable for the kids, hanging in the parents' lap. And like I said, usually they're not this cooperative while we're doing an evening. But yeah, you just want to make sure you get a good look. So you have to tell the parents before this, like, hey, the reason that we're here, we have to have a look to see if there are any cavities. It's going to be really quick kind of thing, but what do you do? Like, and especially if you're doing an ED, they do have cavities. Are we going to be able to treat them chair side? No, they are going to have to be put to sleep for that. So that is how to do any evening. Okay, radiographs. So usually they'll start at 3 and you'll do occlusals. Those are the easier radiographs to do because they just kind of have to bite on it. You don't have it going down into the legal vestibule or anything kind of touching on the bone, and that's where it kind of hurts. So we'll do this first, yes, to kind of desensitize. What we're looking for in this is going to be, of course, for caries, for symmetry, and for supernumerary or congenitally missing teeth. The most common supernumerary tooth is, you guys know? The mesiodent. So yeah, so you will be able to assess if there is going to be a mesiodent on that occlusal x-ray. Bite wings, there is a size 0, 1, or 2. If the kid can tolerate a 2, great. Usually that's a little bit too big, so we use a 1. But Dr. Dixon actually does a really good job getting you guys good at x-rays here. But yeah, listen to her. She gives you a good technique on that. At what stage of development do we start taking vitamins? That's going to be a question. And it's whenever the posterior molars are in contact. And then what are we looking for? Interproximal caries, radiolucency and lubrication. I'm going to add bone height. I'll just say bone. You are going to assess the bone levels. Okay. You sometimes can see radiolucency and lubrication. And if you think you do, that's whenever you will take a PA. So question there. What are some reasons we would need PAs if we have bite wings? And that's kind of like if you question or not, there is some peripheral radiolucency under one of the molars or something like that, go ahead and take a PA. Another reason to take a PA is going to be if that patient has already been treated with focal therapy on any tooth or any teeth, because those are the most common to not last. So yes, the plan is for them to last and keep the space and all that, but a lot of times pulpotomy treated teeth will fail after a year, 2, 3 years kind of thing. So always want to take a PA just to check those for infection. Panoramic. What age and stage of development do we take the first panoramic? This will be around 6, yeah. Whenever the 6-year molars are in occlusion, that's whenever we can take our first pano. Frequency, usually, from what I've seen, insurances cover every 5 years, but the real better recommendation is going to be every 3 years. So, what you going to do? And now you're looking for presence, absence of permanent teeth, valid canines, bone, fractures, and then it's the last resort if we can't get intraoral radiographs. And bite wings, not really as diagnostic, but you can kind of get another general feel in there, very easy for them. describing, know this slide, so put a star by this slide. Infant trauma, usually going to be occlusal. Child with less than 2 posterior and approximate contacts rather than no visible decay, no radiographics. Child with less than posterior and approximate. So yeah, just know this slide. This is whenever if you need to kind of take them. Right, these are occlusals, so you'll see all the anterior teeth. This is from a trauma. You can see the horizontal fracture right there. If we have both a primary tooth, do we reimplant? No. Why? We don't want to damage the permanent successor. Okay. Gullet cavities. What's up with this picture? What's going on here? What tooth is this? This is 19. Okay. So this is K, but what's going on with this picture? There's no permanent successor. And which tooth is that? What is that successor going to be? It's going to be the second premolar.